It's passed. We've got 43 people of the anticipated about, it was about 100 on the list. So welcome. My name's Heather Corlett. I'm the programme lead for the network, and we're delighted to welcome you to our Core20PLUS5 huddle that's going to be delivered by 3 of our 4 health inequalities advisors for the network. So huddles, as many of you all know, are the tools for the network to engage with the system and explore topics. And we're here today to continue the work of the network's focus on health inequalities. As the national team is about to launch their health focus, children and young persons, Core20PLUS5, on December the 16th, that's when that's formally being published. But this huddle's a fantastic opportunity to explore and clarify the alignment between the national model and the work of our advisors on a North East and North Cumbria children and young persons model. And so it's really important today that we receive your feedback. So it's not a sit back session, it's definitely an active one. So as we always do, we start with a few slides on the network. Many of them will just be in the pack for reference. So our vision is about connecting together to enable young people to thrive, connecting over those organisational boundaries. And it's important for today because that represents the system. It's not just about health. The Child Health and Wellbeing Network is across the full system. So the other point that I wanted to highlight is our priorities. These are the priorities that were given to the network from the system, and they are absolutely sort of sprinkled with health inequalities in each of those priorities that you see there. You can see mental health, you can see poverty, vulnerability, it's all in there. So this is really pertinent to the work of the network. We'd also like to highlight one of the areas of work. We have the Children and Young Persons Transformation Programme, which is an NHS England programme. And that's on the next slide, if we could, Amelia. And the important thing to note for today's discussion and the national Core 20 is that's got really established pieces of work around asthma, diabetes and epilepsy, some of the areas of focus of the national programme. And then finally, if I just wanted to highlight the facts of life. Within the network, we push forward and drive forward lots of different pieces of work. And one of them is the Facts of Life that was published about a year ago. It's available to everyone through the website and the links there. And it really is a plethora of information around health inequalities. And it's been the basis of some of the analysis that the advisors have done. So a bit of a whistle-stop tour around the network. Unfortunately, much as Julie Gillan was prepared and we were so delighted to have her chair the event today, unfortunately, she's not going to be able to be with us. So Chris Drinkwater will join us later to facilitate the discussions. Lovely. So without further ado, we will crack on to the presentations from our advisors. Firstly, I will just introduce them to you before they speak. So our first advisor, Luke Bramwell, he's Head of Youth Services and Poverty Proofing and has been with Children's North East since 2013. He began his working career as a youth and community worker in Gateshead, working at drop-in sessions and empowering young people to gather experience and opportunities that they might not otherwise have had. He's a qualified teacher and having worked in adult education and secondary education systems. After Luke, Jenna will join us, Dr. Jenna Charlton. So alongside her role as Health Inequalities Advisor to the network, Jenna's a research associate at Newcastle University, working in speech and language sciences and the impact lead for regional charity North East Wellbeing, who provides services to support children living in deprived communities, including social prescribing. And finally, last but not least, Will is a fabulous trainee paediatric doctor and he's currently based at University Hospital of North Tees. So many thanks, Luke. Over to you.
Thank you, Heather, and hello everybody. Great to see lots of familiar names on our list, and really hope that you feel as though you can kind of connect with us today, whether that's through the chat or through conversations later on. So I'm just and I've got to say it's always very strange when someone's introducing you, isn't it? So that was very lovely, Heather. Thank you. I guess I just want to give a context to what kind of the journey we're going to go on over the next little while. So first of all, we're going to just talk very much kind of about the Core20+5, and I'm going to give just an overview of the Core20+5, introducing the Children and Young People's Core20+5, which, as Heather says, is due to imminently be kind of officially released. And then we're going to go on to talk about, well, what does that mean for us across North East and North Cumbria? And Jenna's going to come and talk about some of the work that we've been doing to really kind of delve into that in relation to the broader system and what that means in terms of health inequalities as well as healthcare inequalities. And then Will's going to come in and give just an overview of how we're using the framework and how we're testing and modelling and how we can use the framework so it has the greatest amount of impact across our region. So hopefully that covers the presentation, but also it's then about connecting. And this bottom bullet point here, we're really interested in what this framework means for you, how you can connect to the framework for people right across the system, right across the network. So let's look at the Core20+5 framework then. So I'm hoping that many of you may well have seen this graphic. I think it's a really useful graphic just to explain what the Core20+5 is. And I'm just going to start assuming that you don't know anything about the framework, although I'm sure many of you have connected with it in some way. So first of all, what does it mean? Well, Core20 is about, ultimately it's about how we can target across the ICS target health inequalities improvements. Okay, so the first thing is that what we know is that health inequalities are really apt, and it's really apt to address health inequalities, particularly for what we might describe as deprived communities. And so the Core20 is about focusing on the 20% most deprived communities across the country based on the index of multiple deprivation. I'll talk a little bit more about that in a second. Secondly, it's about then the plus. The plus is about targeted population groups, those where health inequalities are, or where particular population groups experience kind of worse health outcomes. So targeting specifically those plus groups. Again, I'll talk a little bit more about that. And then the 5 are about the healthcare inequalities and where clinically, nationally, based on national data, we see specific health inequalities. So initially, a year ago, NHS England released this kind of Core20+5, and this is their graphic. And it covers these 5 core areas. So maternity, severe mental illness, chronic respiratory disease, early cancer diagnosis, hypertension case finding. And while these are really important areas and healthcare areas, what we also recognise and what you might reflect is that if we talk about children and young people, there is some connection, of course, within these 5 areas, but it's not the main kind of 5 health inequalities that children and young people are facing across our country. So we've been part of conversations with the national team around really kind of pushing for having this kind of children and young people's focus Core20+5, and consequently are really delighted that there has been or will be a Core20+5 specifically for children and young people. So as you'll see on the next graphic, the children and young people Core20+5 follows exactly the same kind of principles, but the key change are those clinical areas. So where do we see health inequalities and healthcare inequalities for children and young people? And based on the national data, we can see that asthma, diabetes, epilepsy, oral health and mental health are those key 5 areas where we see significant healthcare inequalities. And again, we're going to delve a little bit more into those and actually what that means for us in the North East. Let me just give a rationale for why those health inequalities are chosen. On the next slide, it just gives a bit of a kind of an overview, if you like. This is just an example as to why those areas may well have been chosen or have been chosen by the national team. So if you look at the social gradient, you can see in relation to asthma that basically this is based on the index of multiple deprivation, or disease of multiple deprivation. Those that are in kind of bracket 1 are much more likely, and these are the more deprived communities, are much more likely to suffer or have hospital admission as a consequence of asthma. So you can see very clearly that there is a need to focus attention and focus efforts and resource to those living within that first IMD bracket when related to asthma. And here's some proposed actions that have come through the national teams, and some considerations that we need to give nationally in relation to asthma. But that's just an example, and there could be an equivalent graphic or slide for each of those 5 areas that we've highlighted. And there's lots we could unpick and explore around those 5 areas, not least the low rates of hospital admission in 2020-21, but we know some things were going on then. So that's kind of the core 20+5. I just want to delve a little bit deeper. If we just move on to the next slide. Into just giving the rationale or an understanding around these areas. So first of all, I just want to touch on index of multiple deprivation. I've referred to it, I've used that term already, but this is what or how the index of multiple deprivation is calculated. So it's based on, I mean, it's what it says on the tin, multiple deprivation areas. So it looks at income, employment, and they are the 2 areas that hold the greatest weight when calculating whether an area it features within the IMD. Education, health, and then to a lesser extent, but equally very important, crime, barriers to housing and services, and living environment. So that's how we I don't do it, but how the index of multiple deprivation is calculated, and there's national data around that, and we'll touch on that I think in the next slide. Sorry, the one after this. However, I just wanted to flag something really important here. And that is that the impact. So we talk about the core 20. Now, it will be little surprise to people in the room that actually the 20% most deprived areas of England, based on kind of what we call LSOAs or local super output areas, we have a much higher proportion of LSOAs who are in the lowest 20% based on the IMD calculations. So the data that I'm going to use is 29.4%. However, that is inevitably with data a little bit out of date. What we know is the impact of deprivation in North East and North Cumbria is significantly higher than it is nationally. And so actually it's even more acute. So while we might be talking about core 20+5, actually in North East and North Cumbria, we're talking about the core 29.4+5, but that's a bit of a mouthful. And just when we start thinking about that very specifically and break that down into specific areas, and Middlesbrough is one that's really important to highlight. So in Middlesbrough alone, 57.2% of local super output areas in Middlesbrough, these are small areas within Middlesbrough, sit within the 20% most deprived areas of the country. So again, just the importance of honing in and looking at place, looking at locality. This is really important as we explore core 20+5. And if we look at the next slide, you can see how that pans out at a local authority level or borough council level across the region. And so some particular areas to flag. I mean, if we flag Middlesbrough, which we already have, Hartlepool, South Tyneside, some real significant numbers compared to the national average of 20. The other thing that I want to just highlight on this slide is, while the IMD is a really important measure and tool, and it's the one that we use across core 20+5, there is another kind of deprivation level or measure that we use nationally, and it's called the Income Deprivation Affecting Children Index. Oh, another mouthful. IDACI, we'll call it. So the IDACI is specifically focused on children, and it's specifically focused on income. And what we know based on the poverty rates that we see across North East and North Cumbria is that that's actually a really important measure. And Jenna's going to talk a little bit more about how we've been using that as we've been exploring the impact of health inequalities across North East and North Cumbria. and that's a measure that we might want to explore. So if I just on the next slide, I can just highlight why it's important to maybe consider the IDACI when we're looking at health inequalities. This middle kind of table, the index of multiple deprivation, little surprise that Middlesbrough is top of that list in terms of local authority areas that are affected or have higher proportion or higher rates of multiple deprivation, and Hartlepool sits at 10. If we shift our focus to the IDACI, what you'll see is within the top 20, we have 4 of our local authority areas. And I would argue that we have some in the next kind of 20 to 40. It features a lot of our other local authority areas. We have high proportions of need, high proportion of deprivation. And again, we just want to kind of highlight that because, as in this table on the right, the IDACI is a narrower measure. It focuses on income, and we know ultimately that income is a key determinant of health outcomes. Whereas the IMD, while it's really important, it's a measure that we need to use, and it's a measure that we will use in connecting to the Core20PLUS5, is a broader measure and covers more aspects and more domains. So hopefully that gives a sense and just starts you thinking about what this means kind of regionally. As I say, Jen will touch on that a little bit more shortly. If we just move on to the next slide, just want to highlight the plus groups. So just to kind of break that down a little bit, well, what are those target population groups? And I'm leaving this as an open question because this has to be based on place and locality. We need to stress that. And so there's certain things that we need to consider. So, for example, socioeconomic groups and deprivation, essentially those living in poverty that are living in more affluent areas. There is still some health inequalities, significant health inequalities that those children and young people are facing. So we need to consider that in the work that we use and how we target our provision and resources. There are inclusion health groups, some specific inclusion health group, young carers, gypsy Roman travellers, migrants, etc. So again, well, what does that look like locally? What does that look like regionally? We need to consider that when thinking about where our plus target groups might be. And of course, there's the protected characteristics, and I don't need to list those off because I'm sure we all know them. But we need to think about which of those protected characteristics are most specifically impacted by the health inequalities that we see. This is about the process of drilling down into where the need is most acutely felt. And again, then we can think about how we appoint and direct our resources. And then geography is a really important thing, because when we consider geography, across North East and North Cumbria, we have all of the examples given there. We have inner city, urban areas with great deprivation. We have real rurality across Cumbria, Northumberland, Durham. And then we have coastal towns, both east and west of the country, that fall within our region, where again, we see significant levels of deprivation. So these are some of the areas that we might need to consider when thinking about the plus population groups that we target or focus our resources towards. And finally, I just want to flag on the next slide the 5 areas of health that we might focus on. Oh, we've gone back a bit there. Amelia, if we can just go forward to the next slide, that's it. So I've highlighted those 5 areas, those 5 specific healthcare areas where we see healthcare inequalities around asthma, diabetes, epilepsy, oral health and mental health. These have been chosen nationally. They are definitely relevant for us here in the Northeast. We can see that. We can look at the data around that. And again, we'll talk about how there are some areas within those 5 clinical areas where we might want to or need to focus very specifically on. And there's some questions here. How do we connect to those 5 clinical areas? But let's start thinking as well. I've talked a lot about healthcare inequalities. One of the things is that we're here as a wider system, and we also need to think about and consider the wider determinants of health and health inequalities, as opposed to focusing specifically on those healthcare inequalities. And we're going to go on a little bit of a journey and explore that and hopefully discuss that a little bit more. And the reason why that's important on the next slide, again, this is just some of the information that we've received through NHS England, which is really important to flag. And I'm not going to read through all of that stuff, and you know, it's really useful and interesting. But just this bottom kind of rectangle where it talks about the fact that what we need to do is, or it says there may be further areas that are prioritised across systems, regional and national teams. I think it's within that kind of mandate from NHS England that we need to consider some of those broader determinants and also consider what the Core20+5 means for us across North East and North Cumbria, and actually more specifically within our localities. And that gives us some, an opportunity for us to really explore, really target our provision so it's right on point for children and young people living across our region. So hopefully that gives a bit of an overview of Core20+5. I am now going to hand over to Jenna, who's going to talk a little bit more about how we've delved into this in relation to North East and North Cumbria as health inequalities advisors to the network. Jenna, all yours.
Yeah, thanks, Luke. Yes, I'm just going to talk about where we are at the moment as regards to developing a Core20+5 approach for children and young people in the North East and North Cumbria. Next slide. Yeah, so as Luke mentioned, the 5 national priorities are very much based on a national picture, and they are very high level priorities. But of course, we want to ensure that these are also relevant for our region, and not only just relevant regionally, but also relevant to different sectors, different organisations, and to you as professionals applying the approach in your everyday work. So here we just have some considerations that we would ask you to begin to think about as we move through the rest of this presentation. Hopefully these will shape our later discussions, but thinking about where and how do our regional priorities fit in to that framework? What are the benefits of perhaps considering both a national and a regional framework? And what does the North East and North Cumbria need? What do our localities need, and what do your teams need as regards to addressing inequalities in health? And is there perhaps a case for addressing the broader determinants of health that link to those national higher level priorities? Next slide. Okay, so as Luke's mentioned, there are different ways in which we might explore deprivation, such as the IMD and the IDACI. There are also different levels at which we might begin to explore demographic information. So we started our work by focusing on identifying those localities that fell into our regional Core 20. We did this based on the IDACI as a measure of deprivation, because that is more specific to children. And what we have done is we've been able to map all the wards and lower super output areas that fall into the bottom 2 IDACI deciles for each area in the North East and North Cumbria to support very targeted work. Now, the lower super output areas can be pinpointed using interactive maps, almost down to more or less postcode level, so that users can explore further exactly where these areas are. And we do have this information available as a resource that can be shared with the final framework. For each ward, there is readily available census data. So we delved into the census data and we've pulled out of that some demographic information that we think is relevant for each ward, for each area in the North East and North Cumbria. But what we don't have at ward level are data for other characteristics that we might consider to inform our plus characteristics, or plus populations. For example, those in the youth justice system, looked after children, young carers, or SEN children. Next slide. What we do, however, have at a local authority level is data about those population groups that we may consider as being our plus groups. Now, the Facts of Life report has a lot of this information in, but it's also available via other resources such as the Fingertips and the Office for National Statistics databases. And just as an example here, we know that looked after children in particular are a priority plus group for health. And the Facts of Life report details the proportion of looked after children within each local authority across the region in comparison to the national average. and further divides these by age group. So this really is a resource that can be used alongside the framework to supplement that census level and ward level data. Next slide. Thank you. So in exploring the different types of data that was available at various different levels, we began then to think about how the framework might support the identification of those plus groups. And as Luke mentioned, this varies on locality. And I think it's very much informed by, yes, data, but also your experience. So some plus groups may seem very clear to you, and there may be certain population groups that you see daily in your practice, but some may not have been considered. And there are many ways in which you might explore who your plus groups may be. So here we have some examples of how the framework might support that identification. So we have our demographic data document, which is our ward level census data. The Facts of Life publication details a lot of potential plus groups at a local authority level. And we very much promote the engagement with the public through PPI. Our network's young advisors in particular, they identify the LGBTQ plus community as being a priority plus group in relation to mental health and well-being. And also we advocate for users to explore the evidence base around priority health areas. And this may involve, yes, of course, the use of publicly available databases, but also academic publications and reports. As for the priorities for the North East and North Cumbria region, here we have 5 on the right-hand side that we have proposed here as suggested priorities. Now, I note here that we are very much open to sense checking these with the network, as yet they are not set in stone. But the Child Health and Wellbeing Network Facts of Life report identified 8 priorities for children and young people, which were established in consultation with children and young people. And our 5 suggested priorities are very much born directly out of this. So the intention is for these to align with and complement the national 5 higher level priorities, and for both frameworks to be considered together rather than choosing to focus on one over the other. Notably, the 5 themes that we have here are much broader than those in the national framework, but hopefully still encompass those 5 higher level priorities. And the hope is that by setting broader themes, this allows for the framework to not only address those wider determinants of health, but also for the framework to be accessible to a range of different sectors, individuals, and to support integrated care. So what we are aiming for here is greater local impact, and we want to impact as many people as possible, but also have as many people from different sectors working towards the same goal as possible, as we also work towards those national higher level 5 priorities. Okay, next slide, please. So I'm sure we are all well aware of the importance of ensuring our practice is evidence-based, and we believe that our developing framework very much supports this in a number of ways. So as regards cross-organisational expertise, we want the framework to be, yes, accessible to many sectors and for everyone to share a shared vision and shared goals, and to incite collaboration between sectors, which may be facilitated by, yes, sharing of expertise and best practice, but also by the support of the network. The voice of children and young people is, of course, paramount to any work that we do, and not only will the framework be informed by CYP consultation, but also promotes the engagement with children and young people and their families via strategies such as PPI and focus groups. And I think any action that is taken to implement a Core 20+5 approach must involve informed decision making. Naturally, the framework is very data-led, but also it promotes the exploration of the evidence base around our health priority areas. So whether that be community data, academic reports and papers, but these may be particularly important when we consider identifying who our plus population groups are. Next slide, please. And here we just have some examples of how the Core20+5 approach may be applied across different contexts. So whilst those components of the Core20+5 fit very well together to provide a holistic, targeted framework, each holds their own individual value and can be used flexibly across different contexts and work streams. So you may be already delivering support in one of those 5 priority health areas, but would like to perhaps target your provision to more Core 20 localities. The framework can help you do that. You may want to support health inequalities, but don't know which area of health to target or who to target. Or you may want to connect with other Core 20 localities to enhance the reach of your already targeted work, and the framework can very much support that as well. Next slide. Now, what we are aiming to develop is an infographic which combines both the national and regional models, and Luke can speak a bit more about this now.
Great, thanks, Jenna. Yeah, thanks. I just want to kind of be really clear about what this is. What we've talked about is so far is the national Core20+5 plus what does that mean across North East and North Cumbria? And this is just an evolving, a developing infographic, and we will kind of firm this up, we hope, and share this. But what it does is it takes the Core20+5 and add some locality to it. So those 5 clinical areas absolutely front and center, and they need to be. It's really important that we look at addressing those. But just following on from what Jenna has highlighted, there's some very specific areas that we might be looking to focus on. So asthma is obviously one that we flagged, self-harm, as Jenna has talked about, but also some of these areas that navigate across all those 5 clinical areas. And what we see from some of the data and the research that we've been doing are those 3 areas: best start in life, food security, family life, and how they play a really key part. Now, when we're looking at this as a whole system and right across the network, this is maybe a useful way of viewing the Core20+5, that yes, as those national priorities are absolutely vital, but what does that mean regionally, and how can we target not just in those areas, but some of our work may focus much more on food security or food insecurity or family life, etc., etc. So this is it's an evolving graphic that really helps to kind of hone in and start us on that journey of thinking about what this means in my role here across North East and North Cumbria. So hopefully that's going to be a useful tool, and we will be sharing this infographic, a kind of slightly updated version of this graphic as we move forward. But this is how we're trying to frame. So it's not. I think I just want to flag. It's really important to say this isn't. We're not saying we need to ignore the national stuff. We're just going to focus on these wider health inequalities. Well, that's not real. That's not going to help us in our day-to-day. What we're saying is those 5 healthcare inequalities are really important, but actually there's also some scaffolding around those 5 areas that we can do in targeting our delivery. So hopefully that pulls together what Jenna and I have talked about over the last 20 minutes or so. Jenna, there we go. Okay, well, I'll hand over to Will. Thanks, Jenna, and Will, over to you to share how we've been looking to use this.
That's great. Thanks, Jenna and Luke. I just wanted to introduce our pilot that we've been doing, because we wanted to kind of have a kind of implement it in the framework in a practical way and learn something ourselves about what it might look like, and also kind of be able to present to you something a bit more kind of tangible and less kind of theoretical. So we decided to look at self-harm in Northumberland. And we did that because when you look at the facts of life document and the data, Northumberland comes up with very high rates of admissions for self-harm. This was taken from 2020-21. Actually, the year before that, Northumberland was the highest in the country, and obviously now it's only second to North Tyneside. It is worth mentioning that hospital admissions as a result of self-harm might not be truly representative of incidents, because it might depend on the local hospital practice, etc. But that variation will exist across the country, and I think those numbers are still of great concern. So that's why we honed in on there. So next slide. So if you look at Northumberland and try and identify the Core 20, this is what you'll come up with. So you'll see that the most deprived 20% have mainly centred around and clustered around Blyth and Cramlington, Ashington, but there are also other pockets within smaller pockets within Berwick, Amble, Morpeth and Hexham as well. And there's a list of the wards that are in the most deprived there on the left. That's great. Next slide. Yeah, perfect. So when we initially set about trying to think about plus groups, we went to the literature first just to get some ideas. And you can see on the right hand side that there are a lot of significant parental factors such as unemployment, whether they're a lone parent, the parental education, as well as income and type of accommodation. And other factors that we thought might be relevant looking at the literature were young people identifying as LGBTQ+, those who are looked after, and also refugees and asylum seekers. Other things we learned were that that self-harm can look very different in different communities and across different sectors, and that as I said before, the presenting to hospital really is just the tip of the iceberg, and that might not represent the community burden. It might actually be look quite different when you explore deeper. And there is literature from, particularly from London, just warning that that young people may express emotional difficulties or emotional distress through different ways among people from different ethnic minorities, and that mustn't mean that they lose focus or that emotional distress isn't still identified and addressed by services. Yeah, so next slide, please. There's some other interesting things in the facts of life. So now we've taken the broad data, now we're honing in on what it looks like in Northumberland. So if there's a red dot, it means it's significantly worse than the national average or significantly higher. You can see that there are higher rates of looked after children, but that's mainly among the under 5s rather than the 10 to 15 age group. But you can see on the 5th down, the percentage of looked after children whose emotional well-being is a cause for concern is significantly high, and I thought that was a really interesting point to bring out of the facts of life provided us. And then there are significantly less who entering the youth justice system, less young carers than the national average, less people who might be experiencing homelessness, but that alcohol, admissions due to substance misuse and alcohol are particularly high in Northumberland. So that it doesn't remove any of the groups that we might need to think about, but it might just begin to shape our direction. Lovely. And next slide, please. So when we thought about how we might go about applying the Core 20+5 framework in Northumberland for self-harm, we thought that we initially started by sharing regional best practice via the network, and I'll highlight that at the end of the presentation because that's still ongoing. And then we wanted to kind of think about how we might identify current practice in the area, begin to further hone down on the plus groups and think about gaps in provision. And we've completed a professionals focus group, and we are in the process of carrying out a parent carer questionnaire, and we'll be shortly facilitating a focus group at Bede Academy to try and unpick that a bit more. Next slide. I wanted just to share some of the themes coming from the professionals focus group. So some of the ways that poverty seems to affect self-harm within Northumberland are the rates of parental substance misuse people talked about. They felt that there was a high association of presentation of self-harm with intoxication. They felt a few of the professionals had worked in other areas such as Newcastle, and they really spoke highly of services such as Streetwise that really provide support for emotional well-being between school hours and the home, but they felt that this was very limited in Northumberland, and because of the geography, things were really people would struggle to access it in the same way. They noted situations where people's emotional health were impacted by the combination of food insecurity and poor sleep, which seemed to kind of really join together to exacerbate one another. And there were also issues with transport and childcare that were raised. Some of the plus groups that people felt, from their opinion, were potentially experiencing poorer outcomes were those from LGBTQ plus communities, particularly looked after children. Interestingly, they raised the issue of young people who are transitioning, who are sitting between paediatric and adult services. People also said that over the last couple of years, they'd felt that the number of young people with special educational needs or autism also presenting with self-harm was rising, and that this presented a real challenge, and that there wasn't as many services that were suitable for them out there. Felt that was a gap, and they also highlighted repeat attenders as well. So we tried to think about 5 possible actions that we could take from this meeting, and they included looking at data knowledge, particularly looking at multi-agency referral forms, which really capture some of the issues that aren't necessarily presenting to secondary services and hospital. They talked to the importance about poverty proofing, assessing community assets, because we felt that there was a lack of support there, but it's important to really dig deep and look at what you've got and what's currently available, and what you can build on. They felt that there was an issue with unclaimed benefits, and that this would link nicely with the Northumberland Poverty Plan, and maybe within that plan more of a focus on self-harm could occur. Next slide, please. So we've had this was a real learning process for us. We wanted to look very practically at the framework and think about what we might learn from it. We appreciate that we had the chance to go above and beyond and do some extra things within this space, but it really made us think about the importance of managing resources. People might not get any extra budget for adopting a Core20 Plus approach, and I suppose it'll vary between issue and geography, but it is really important to use, and the framework might be more of an adjustment to your current structure and your current aims, rather than adding huge amounts of extra meetings or groups into your work. Something that we hadn't quite appreciated would be quite as effective is actually using a Core20, the 5 part of the Core20+5, and thinking we can talk a lot about the Core20, we can talk about a lot about the plus, and you can really spend a long time trying to untangle these issues, but actually what are your 5 goals going to be and what's achievable and what's the next most effective step that you can take. And that might be implementing something new, but it might be changing your orientation. For example, looking at what is your PPI at the moment, who makes up your focus groups, and is that representative of Core20+ groups that are relevant? And when you're looking, it's very easy to want more data and try and understand it more, but what piece of data would be the most useful moving forwards? You know, which direction should you go in terms of trying to collect the data? Another thought is just that we can collect lots of information about Core20+ groups, but it really takes the people right at the top wanting to know and caring about what's going on for people who are experiencing health inequalities, and really trying to create avenues where people are able to access the information and be able to listen to the people who are suffering. And that the Core20+5 approach is going to be a dynamic process. It's not going to be something we're going to be able to just tick off. It is something that is okay if we slowly strive towards it. Next slide. This is just a link to, if anyone's working within this space, please do share your work, so we can try and share it best across the network. So there's just a link there that you can follow if you're interested. That's great. Next slide. So we're just moving on to the discussion, I think. Yep.
Hi there. Good morning, everybody. I think we've got a bit of space now for discussion before we move on to a comfort break.
Yeah, that's right. And apologies, okay, Chris, I wasn't off mute fast enough to pass a huge thanks to you. Chris Drinkwater, many of you would have seen on some of our other huddles. He's been connected to the network for the last 4 years, and he has a formal role as our VCSE representative on our executive for the North East, and also he's operational oversight group chair, and he's stepped in at the last minute, so we owe him a big thank you. So appreciate that, Chris. And yes, after that welcome, we have the comfort break, and the questions are on the slide for the comfort break. So shall I hand over to you, and Amelia, do you just want to show that slide? So there's a few presentations first before we cut to the questions on Menti, but Chris thought it was helpful to have them in the break, didn't you? Thanks, Chris.
Yeah. Okay. So quick comfort break is at 10:55. So we've got time for a few quick questions.
Of course, yeah.
Were there any questions in the chat that people wanted to pick up? In the meantime, while we're having a look at that, quick one from me, Will, in terms of self-harm. You didn't talk about work with schools. Some evidence that self-harming behaviour is being seen in younger ages, and certainly in the primary schools in West Newcastle that I'm involved in, self-harming behaviour in year 5 and 6 in primary schools is now occurring, and schools as a source of identification and action are something that we shouldn't neglect.
Yeah, absolutely. Yeah, totally agree. And your point about ever younger presentations that was also picked up by the professionals as well. So I only introduced it, but we are carrying out a focus group at Bede Academy to try and look at more about the school setting. So that is definitely in process, and I think connecting up the mental health practitioners with what's occurring in schools seems very important. There is also in Northumberland, they have introduced counsellors as part of a trial there as well. So
okay, thanks for that. I can see a couple of hands up, Lorraine and Hughes, and then Liz Lingard. Lorraine, do you want to kick off first?
Yeah, thanks. And we may want to just pick some of this up after as well, but I mean, obviously the priorities that have been set out have come through a lot of the work that's come through the network and the executive, and I can see there's a lot of support for them in here. Obviously, I put in the chat before, I'm here representing the DPHs, the regional DPHs, and as people know, that there is concern about having two frameworks. And we can probably come back to some of this after, because there's concern that it causes confusion and it'll also dilute some efforts, but I don't see them as mutually exclusive, if I'm being perfectly honest. So I think some of the other things that sit underneath it, like the best start in life, the work will happen anyway. I can see the comments Becca Scott's put in, and there's a core 20 for maternity, etc. But one of the things I wanted to pick up, and I think it highlights the point I'm making about the concern of confusion and dilution. There's been a lot of talk this morning about, you know, that we've got a national one, and Jenna, you said this in your presentation as well. We have the national Core 20+5 for children and people, and it's great that we've got that, but you feel we need a national and a regional framework. My point is, it's implying that the national framework that has been published or will be published soon and launched isn't regional, but it is. And this is what I mean by the confusion. So that national framework will be there, but it will be, the regions will be held to account on it, and they'll have to deliver it. And so I can already see how some of the language being used is causing confusion or could cause confusion. It's not that there's a national one sitting over there and it's in its own little bubble. You know, all of the ICB, you know, so the ICS and the ICBs that sit in place will be expected to deliver against that national framework. And I absolutely appreciate, Luke, that that it's in the infographic, you know, and that's right that it's there. But I do feel really strongly that already the language used today is causing that confusion. And I didn't want people to think, well, actually it's that, but then we've got our own. So I do think we need to be really careful. And there is that concern from the DPHs that it will dilute effort. Now, it might be that what we have is the priorities, you know, because the priorities and the transformational priorities and what's come through from the network and all that work that's happened is absolutely valid, and we want to deliver on those. But does it need to be described as another framework? I think is my challenge back, because we have the framework. There's some really good examples already about the self-harm work and the asthma work and things like that that feed in and complement, and absolutely recognise that there can be system priorities as well as these clinical priorities. And you know, like I said, I'm not disputing that at all. But is it that we need two frameworks, or is it that we have the children and young people's Core 20+5, and that is driving that work around those healthcare inequalities, and then we have those system priorities that sit underneath? So I would just really welcome as the discussion as we go through some other people's thoughts on it, because I think we need to have that discussion. And I think it picks up some of Becca's points as well that she's put in the chat about how it then cuts across the, you know, the other areas as well. Because there's lots of different frameworks.
Okay, Lauren, thanks for that. I think we can pick some of that up in after the break. But I've got a quick comment from Liz and then Heather, and then we probably need to go to the break and sort of pick up some of the discussion following the break.
Yeah, and
Liz.
Thanks, Chris. Just wanted to follow in on that point, because I think, although we've said it's the ICB Core 20+5 framework, actually what our ICB has done is gone ahead of what other people have done with the sort of adult Core 20+5 as well. So they've honed in on those areas to look at what the system priorities are. They've done work around appreciative inquiry, so they've got beneath the data to go in and work with those local communities to co-produce things. So I think it's more of a language thing, Lorraine, as you've said, and the infographic's really clear that you've put the Core 20+5, which is about healthcare inequalities, into the context of the wider ICB work, and you're looking at those cross-cutting programs around Best Start, family life, and poverty proofing. So you've sort of, you're probably ahead of the game, but I don't think you're changing what's happening, and it might be just a very minor tweak around our language to make it very clear that what we're doing is moving on by doing that appreciative inquiry to get to what the priorities are for North East and North Cumbria. So I think we're on the right track It's just about the language of how you land it. But great presentation so far this morning.
Thanks, Liz. That's very helpful. Heather, quick comment from you.
Yeah, thank you. And just wanted to say the purpose of today is to have that discussion, and we have requested to sit and attend the Directors of Public Health meeting. So absolutely, that's what we want. We want a dialogue, and like Liz says, there's language is playing a huge part here, and I think you've registered the challenge, and we can take that into the Menti questions this afternoon, because that's the purpose, to get a feel from the system. We don't want to cause confusion, and so absolutely want to work together to get to a different place. But that's the purpose of the afternoon, the second half of today. Thanks, Chris.
Okay, thanks for that. Comfort break. 5 minutes and some questions for you to think about. And when we come back, we're looking at some very brief case studies to give you examples of action, because the usual thing is lots of data, but we need to use the data to take action and to move things forward, to make changes. So some quick examples after the break. 5 minutes. If we see you all back again in sort of 5 minutes time, that would be great. Enjoy your coffee.
Thank you.
Heather. Hello. Hi, Heather. Are we all back? Is everybody ready to restart? Welcome back, everybody.
I think, yeah, we got thumbs up.
Okay. Luke, do you want to respond to the questions, and then we can go quickly to the case examples and have some further discussion?
Yeah, that's great. I think thanks, Chris. I think really interesting discussion already, and hopefully lots more of it to come. I think just to pick up on the point that was discussed at the beginning, and Lorraine, great that you flagged some of those concerns, and you know, we're delighted to come and have those conversations with the DPH kind of group moving forward. But I just want to be really clear, because I want to make sure that our communication through this is really consistent. And what we're saying is that there is one Core 20+5 for children and young people, which we champion and we support and we think is great. I think what we're moving towards is that layering on top, which is looking at the regional, what that means regionally. So just so everybody is really clear, we're not suggesting that there's two frameworks of Core 20+5 for children and young people. There is one. We have the national model, and that infographic that I shared is about us layering on, which is exactly what we've been asked to do across the ICB. So really keen to have those conversations, and some of those we can have outside of the this session, but just wanted to make sure that clarity was coming through here for everybody.
Okay.
Great.
Thanks, Luke. Will, I gather you've been sort of gathering together the case studies, and we've given people a slide and 1 minute to present. Do you want to sort of take over and run through the case studies?
Yeah, can do. I think we have some questions from registration as well, which we could just, if we go to the next slide, if I'm correct, or maybe it's straight into cases. No, it's straight into case examples. So it's Rachel first from Children Northeast. So yeah, I mean, obviously I introduced the pilot, but we thought we'd try and get a good breadth of different examples just because people will be from a real range of backgrounds here, and we want you to try and pick out what you know, something that you might relate to. So anyway, I'll hand over to Rachel first, and yeah, we'll give people max 2 minutes, and we'll move on, I think. If that's okay.
Thanks, Will. Good morning, everybody. I'll try and keep this to 2 minutes. So today I've been asked to review and reflect on the Core 20+5 approach in line with the work that we currently deliver at Children North East. I suppose operationally, and the principles within our work to reduce inequalities for children and young people is at the heart of Children North East's strategical and operational plan. And we're currently providing a number of mental health services across North East and North Cumbria. As an operational manager, I wanted to focus on some specific target groups and advocate for inequalities faced by a number of children and young people facing those specific challenges, as already mentioned. Within that, I had a number of reflections on how the framework will affect my decision making operationally. And some of these include that Children North East were continuing to provide mandatory training for all staff in terms of equality, diversity, unconscious bias, poverty and youth mental health first aid. And we're building on that CPD programme. We advocate consistently for children and young people from diverse backgrounds with varied experience of poverty, and those include asylum seekers, refugees, those with SEND and neurodiversity, to ensure that they receive tailored mental health support. We work collaboratively and together with the VCSE Alliance, ensuring that we share best practice and challenge decision making. And by doing that, we facilitate working groups to communicate effectively on policy and procedure. And by obviously that leads on to identifying and mitigating any risks of delivery of planning effectively and assuring all targets are met. But I suppose most importantly is continued feedback and discussion with the decision makers within ICB and different stakeholders around waiting times, and having discussions around how a 6-session model isn't as effective as it once was due to the complexity of cases that we're seeing. We really need to be accountable for the improving outcomes by using a range of recognised methods to evaluate impact for the young people who are presenting at our services. Thank you, Will.
Thanks so much, Rachel. Thanks. Move on to the next slide. Lovely. So this is from Emma Lim. Thanks so much, Emma.
Can you hear me?
Yep. Yeah, hear you fine. Thanks. Yeah, you've got 2 minutes.
I'm here to talk about the Healthier Together North East Northumberland website and also our app. And Laura Cassidy, our project manager, I think is also on this call, and I'm sure she can add. I think one of the important background issues for this is about something that Liz brought up so clearly. It's about inclusivity and the inequality of access to healthcare. And that is really important because we see this in a number of ways. So what we see an enormously high paediatric emergency department attendance and a lot of GP attendances. But a lot of those are for minor self-limiting illnesses that in other communities, people feel confident about coping with at home. We know that in our region, this is a bigger problem than most. So we have higher rates of A&E attendance compared to the English average. So we developed this health site. It's part of a national health site. We already have some data on a national basis that shows that the Healthier Together programme has been shown to reduce unnecessary attendances in ED in other areas. And there is literature to show that we have focused on some of the core things that are acute illness problems that you've talked about, so asthma and diabetes. We've also got a large mental health section. But I think that I wanted to bring some really practical solutions here. And one of the things that makes inclusivity a problem is that if you have poor literacy, poor health literacy, or English is not your first language. So these are all some of our plus group here. And on our website, we've tried to address these in very practical ways. So we've got easy read versions, we've got translations of core information, and we've got Recite, where the website will actually talk to you. It's also really important to think that you can get this information on a phone, so you don't need a computer, and there is an app that is downloadable that works with your GP, so you can get better access to your GP through this app. I think it's really important that the work we've done is in co-production. So we've worked really hard with our regional leads and also social care and other areas. The Young People's Advisory Group Northeast has looked at our mental health and sexual health sections, and we're due to actually access, we're working with Professor Greta de Fater to do a sprint in the new year so that we can access some of these hard to reach groups, particularly of young people who might not otherwise be involved in this kind of work. I don't know if Laura's there and she wants to add anything else on.
I think we'll have to move on, I'm afraid. We are covering some more about the app at the end of the presentation.
Perfect.
So, yeah, so next slide, that'd be great. I'll give you another 2 minutes. Because Emma's kindly doing our next one as well about hospital admissions.
This one is particularly about giving people food for thought. So I don't have solutions on this, but we did a really interesting piece of work where we asked families, how much does it cost you for a hospital admission or attendance? And we looked at families who were visiting the Great North Children's Hospital, both as an emergency department, but also more complex children, so the oncology children. And thinking about how that impacted more on our Core 20 or plus groups than the average groups. And the data we got out shows that parents on average are spending around £85 a day to visit or stay in hospital. And that's broken down in cost for parking, cost for food for parents or visiting siblings rather than just the child who's sick, childcare for other family members, and most importantly, loss of earnings. And that is a huge problem if you think about 0 hours contracts, which so many of our families are on, and also about loss of earnings through lost opportunity. And this also looked at the emotional cost to the family when one member is, so for example, if the mother has to stay in, and the impact on the siblings. And so we wanted this to come into the discussion to think about where in your areas where you think we could help. So there's some things in the hospital, there's things in the community that might aid reducing hospital attendance or accessing alternative services near a home and preventative strategies. So we were really interested to see how other people could inform us and how we can solve this problem.
Thanks, Emma. That's brilliant. Thanks so much. We'll move on to the next slide. That's brilliant. So is Esther on the call?
Yes, I'm here, Will.
Lovely, that's great. Thanks.
Can you hear me?
You've got a couple of minutes.
Yeah, thank you. So the project from Northeast Hospital is looking at the Core 20 plus rather than 5. And although when we started our project, the children and young people's framework had not been published, we used the same adult framework to apply onto that. And this is looking at DNAs, and it's a pilot that we are doing in Northeast, which will be rolled out across the whole ICS. And what we've done in terms of risk analysis is used our in-house health inequalities dashboard to identify the areas with highest DNA rates. And that was the pediatric department and mostly the under 5s that had the highest DNA rates. In terms of identifying our plus groups, we've done a number of risk stratification using national evidence-based sources to understand who are the children and young people who are likely to DNA. And these include children living in poverty, children who might be acting as carers, or living in the most deprived wards, or on the safeguarding routes. And also where there are multiple children in the families, those children are likely not to be brought into hospital, and that where there are issues with health literacy, and again with transport costs. What we've the full pilot is going to kick off from the 1st of December, but the interventions that are being put in place is to use a personalized care model using a social prescribing link worker. Therefore, which means that we contact we identify those families who are likely not to attend clinic, and then we put in place a package of support around them. Now, this will then at phase 2 be linked with the wider system. We are piloting it initially in the hospital. Phase 2 will include the VCS, primary care, etc., and wider partners to help expand that pathway. And then also we're looking to do further insights through co-production with people with lived experience as part of that project. And as part of our evaluation, we'll be comparing the impact of a personalized care model for supporting children and young people to attend clinic versus our current DNA national strategy, which is about if you are not able to attend based on 2 or 3 contacts, then we refer you back to the referrer. So that model is going on. And we'll also look at the impact pre and post the intervention coming into place. Thank you.
Thanks so much, Esther. Cheers. Thanks. That's brilliant. Thanks so much. And finally, we've got Catherine, hopefully.
Yeah, I was just going to talk about the cost of living, and this is something ongoing, so it's something we're all working on. So these are just some general ideas about it. So it's a cost of living affecting us all, but particularly the 20% most deprived, poorest areas, because the highest price rises are on the most basic goods, and they're not keeping up with benefits, and wages aren't keeping up with that. Some of the plus groups most at risk, obviously the importance of pregnancy and particularly early life can have a significant effect on your whole life, and children with disabilities or chronic health conditions might need to use more electricity or more heating for some circumstances. And then also thinking about families that are homeless or in poor housing as well. Looking at clinical areas, so there's asthma. Obviously we know the links with cold homes, damp, mould, etc. And also we know that mental well-being and risk of suicide increases. Suicide increases when there's economic hardship, and you don't need to have a mental illness to die by suicide, which is something sometimes people might not think of. And the best start in life, obviously we talked about that with early life, but also the food insecurity. So the prices are rising on the basic goods, but also that sometimes that's a bigger concern than to families in poverty than the heating, because they can turn the heating off, which obviously isn't ideal, but the food is sometimes coming out as a big issue as well. And then actions, obviously co-production is important, and we've got the Poverty Truth Commission, so no action, nothing about us without us is important in that. And when we're talking about actions, we're considering short and long-term actions, because some things take a long time, thinking about the types of actions. So looking all around, looking up, can we advocate, get involved with any of the national poverty charities? Is there things we can do ourselves, like advise or change our own processes? And is there things we can do to take multi-agency action? And obviously prevention is better than cure usually. So is there things we can do to prevent poverty, get people out, how treat the effects, and the importance of evaluation. So making sure, is the process actually in place? Is it working? And is it effect on outcomes? And what can we do to improve that?
Brilliant. Thanks everyone for those contributions. That was great. Sorry for kind of whizzing between you all, but there was a really nice variation there. So thanks again.
Lots of great practical examples there, and lots for discussion. We've got some questions that were raised at registration. You may remember when you registered on Eventbrite, you were asked whether you had any questions. These are the kind of ones that have been picked up so far: service equity, issues between trusts, variation, if you like, in terms of specialist nurses around asthma and epilepsy and health psychology, looked after children, focus on special educational needs and physical inactivity. I don't know if anybody wants to pick up and respond to some of those, or whether we can pick some of those up in general discussion. Does anybody want to pick up specifically? Will?
We could move on to the questions, and then hopefully those themes might kind of come out, I think, in the,
okay.
Yeah, just wary of time.
Any specific questions? I mean, my comment on sort of Esther and Emma's presentation, particularly Emma's presentation about costs of attending hospital, there's a kind of link up almost there in terms of access, and a conversation in terms of looking at those two projects might be quite interesting. Esther, you've got your hand up.
Yeah, thank you, Chris. I just wanted to say those two connect very closely together, and some of the evidence that we used before we put together our pilot projects highlights to some of the things that Emma has mentioned. So cost is one of the biggest thing for hospital attendance for children and young people. And particularly what we found was that when a family has more than one child, then aside the clinic appointment itself, that family would have to look at arrangements for the other siblings to get them into school. That comes at an additional cost. The other thing is where they live, the transport routes and the transport costs to be able to get into hospital. So that's another area that we're looking at. And this, I mean, we only had 2 minutes, so I couldn't go into too much detail. But some of the things that we're trying to do is to do an analysis of all the bus routes and look at where our patient cohorts are coming from to be able to understand the transport routes to those areas. Sometimes it may not necessarily be the cost, but if you've only got one bus coming every hour, then it means if we give that child an appointment at 8 a.m. and they miss that, then they've missed the appointment. And we're also looking at those families where there's a frequency of DNA for those particular children. So that's why it's a piece of project that we're going to do across the whole region. And that's an NENC population health management project that we're looking at. But it looks very much, it builds very much onto the wider determinants of health. And I think that's where the, linking it with Lauren's initial query, although we've been given a framework from a healthcare perspective to help us to prioritize what issues to focus on in terms of the 5. If we are to focus on the core 20 plus rather than just the 5, then the core 20 plus can be applied to anything we do. It's just a way of prioritizing and making sure that we have a constant focus on addressing health inequalities. Because whatever topic you take, automatically you've got to address the whole system and the holistic package of care surrounding patients. And I think sometimes we confuse ourselves with, are we addressing the wider determinants of health versus are we addressing the healthcare health inequalities? The healthcare health inequalities might be the what we've been tasked to do, but the how we address it, automatically we cannot do that without addressing the wider determinants of health. And that's why we have to work across board with all our partners and our system partners if we're going to be able to support our children and young people effectively.
Thanks, Heather. That's Esther. That's very, very, very useful. Emma, you wanted to come back.
Just to say,
thank you, Esther. Yeah, that's right. I absolutely agree with you, and I think there is a really nice natural fit with that. Just to talk about, I think your work with the travel is really interesting. We've done some. I think this is a huge problem in Northumberland because of rural areas. So we've seen people have real problems traveling for long distances, and then particularly when the family is split over a long distance, anybody visiting encompasses huge costs, and people sometimes have to drive in cars because of the lack of bus routes, and parking is incredibly expensive. So I definitely think there's something about rural travel. I also wanted to pick up on your point. I think I agree with you about focusing on the core 20. It bothers me this 5 diagnoses are very set. I'll give you an example. I think saying asthma, a huge portion of our work is in under 5-year-olds who have respiratory illness and recurrent viral-induced wheeze, but they wouldn't be diagnosed as asthma and therefore would not fall in that route. But we know that they're a huge priority in our area, that under 5-year-olds, poor housing and environment all lead into that. And I also worry, and I think Helen Leonard has brought this up, we have a lot of children with chronic illness, complex diseases, and undiagnosed diseases that don't necessarily have one label. And I think that they then don't fit into a category, and that risks them being left out of this framework. So I do think that I agree with you that focusing on core 20 rather than the specific conditions sits better with me, but I'd be really interested to hear from other people.
Thanks, Emma. Will, did you want you were about to make a comment, I think.
No, I was. What was I going to say? No, and I think that's why we want to begin the. I think you're completely right, Emma, and I think we feel that maybe some of the broader themes that we've highlighted that might underpin this might have an effect on all of the above, though all those 5 key healthcare outcomes, but also the things around them which get missed quite often. I just wanted, people have already started engaging with the questions, which is great. So I'll just encourage anyone to, if they can, ideally on another device, I guess, is to log on to Menti, because as Chris goes through the questions, you'll have your opportunity to contribute at the same time. So we hope.
Can I just jump in there, Chris? Sorry, just to respond as well to Emma. I think that this is really important because we can use Core 20, we can use Plus, we can use Core 20 Plus, and we can use Core 20 Plus 5. In theory, we can. I guess there's a bit of a question there: is are we going to do that? And is that the way that we connect in our work? Because even if you're working in a clinical area that isn't one of those 5, then it's really important that we connect to the Core 20 Plus 5. I mean, from my perspective, across the region, we want to share the different ways that people can connect in those different. I mean, as a VCS sector, I don't necessarily directly work in those 5 clinical areas, but I definitely work with Core 20 and I definitely work with Plus. So and for me, that's okay. And I guess there's an interesting question, isn't it? Is that okay for everybody? Is that how we should be part of the interpretation of it?
Thanks, Luke. And just before I bring in Liz, who's been waiting very patiently, the Menti, can we sort of bring that back at the end at sort of say 11:45, and sort of bring in the responses and feed that back?
So I would go through there's 4 questions. So if we just start with those questions, then they'll run alongside the Menti. The Menti will then run alongside. So if we go to the next slide, I think. Hopefully it should. Yeah.
Is it the next slide, or do we need to go back?
No, okay, that's perfect. And then we've got four questions over this period of time. So
can I just bring in Liz first, and then we'll move to the questions.
Sure.
Yeah,
Liz.
Thanks, Chris. And it was just to follow on from what Esther said very eloquently about looking at that Core 20 Plus across all areas. There is a regional task and finish group set up looking at children and young people's recovery and restoration of elective care services, so including outpatients and inpatient care. And at the outset, we know that children and young people's services as a whole have recovered much slower than adult services, and that's because there's been a disproportionate focus on adult waiting lists and targeted funding around community diagnostic hubs and looking at high volume, low complexity pathways and increasing, day case rates there and theatre productivity, but all very focused on adult procedures. So there's lots of work to do in that area. And I think as a standard, everybody should be looking at all of their clinical service areas through that lens of the Core 20, which you can do relatively easily. At the outset, we know ethnicity recording's not great. That's one of the national priorities. So we need to do work around making sure that we've got really good, complete data around ethnicity recording. And then a lot of the plus groups as well. Learning disabilities is good in primary care, but it's a mismatch between what's in acute care providers as well. Lots of work happening, I know, in Newcastle and other areas around that. But all those other groups that you want to look at, disabled children, SEND children, people with autistic spectrum disorders, we really need to drive up and improve the quality of the data to be able to have a data-driven approach to all the improvement work that we do. But those areas around elective care restoration and also that area of emergency care as well are really key to tackle those. And as you've mentioned, tackling those will help support those 5 clinical areas. And just to comment about those targets in the 5 clinical areas, they're not saying these are the only things to focus on. The national programs work together with the Children and Young People's Program to say these are the things that are definitely healthcare inequalities, that is in the gift of the NHS to solve, and it's where we see the greatest step change between the most deprived and the second most deprived quintile. That's why they've chosen those. So it's not to say these are the only things to focus on. It's kind of a way of the national team being held to account for delivery of their program. But I think it's based on national data. So every ICS will have different priorities, and what you're doing is definitely the right thing to do, is to have a data-driven approach, look beneath the data with those communities and tailor what you invest in and what you target doing going forward based on a combination of the two. Thanks, Chris.
Okay, thanks, Liz. That's helpful. Esther, you wanted to come back quickly, and then we could sort of move to question 1.
Yeah, I think I was reflecting on the presentation that Luke gave at the beginning, and in terms of you applying the Core20+5 framework for our local areas. And I was reflecting on what we've been doing in terms from the adult side, which we could almost replicate for the children and young people's side. Because the Core20+ framework that's been published nationally, they've used a set of data sets to identify the 5 that are the highest in terms of disease burden that cause health inequalities across the whole nation. And those are priorities that we all have to look at. But from a regional perspective as well, there are other things that we could look like where we felt were priorities for us. So for the adults, some areas may have gone to Core20+8, for example, because they know that they have other burning issues that need to be addressed. But what needs to be taken into consideration is the available resource in order to be able to do what. And what we have to reflect on is, based on the resources that we've got, how much traction will we be able to place on whichever priorities we go for? Because if we go for a very broad range of priorities, it becomes difficult because we stretch ourselves too thin and the resources may not be sufficient. But if you've got very focused, limited number of priorities that we are all going to focus on across the region, then that's what we are all putting our energies in. But when Luke shared his presentation, he showed different areas in terms of place where there are highest levels of deprivation for different things. And it could be that those places then focus on the additional priorities that we think that we may have in the system. And based on their learning, we could then roll that out across the region. That way we are not all trying to do 1,001 things at the same time. And also for some of the projects, that the priorities that you've already highlighted, which are being led in the system by other areas, then it's a case of we are assured that that's going on. So some of the best start in life priorities that was put on is already being led through the adult route, but through public health prevention in maternity. So almost everything that you listed there is already being done through that route. So once we are assured from a children and young people's network that that work is already being done, yes, it's still a priority for us, but it means that we just link up with those who are delivering on that priority for us. And we assure ourselves that that priority is being taken forward. And therefore, we don't go on to replicate that. And I think that would help us to be able to focus on what we specifically need to do as a children and young people's network versus what we collaborate with other partners and other sections within the system to make happen, because it's a priority and of interest to us.
Okay, thanks very much, Esther. That's very useful in terms of that focus on place and looking at priorities and recognizing that we need to focus and we can't do everything, but those choices need to be made at place in response to different needs, basically. Question 1, Will, or people who are looking at the Menti, any comments that people want to feed back about that, the benefit of adding NENC Child Health and Wellbeing Network priorities to national, and I think I'd go back to, these aren't necessarily different priorities. This is a focus on the Core 20, and looking at what underpins, if you like, some of the diseases, asthma, epilepsy, diabetes, etc. So, any comments from anybody, or is there stuff coming in from the Menti responses?
I think Luke will have. Sorry, Luke. Will have those.
Will, do you want to come in with responses from Menti?
Yeah. Some people have commented about having better focus on priorities in the North East and North Cumbria, and the importance of aligning with the healthcare inequalities. So these wider focus on the wider determinants, also aligning up with the 5 national priorities, and it also kind of gets the sense of locality as well. I think people say there are lots of people talking about the need to include disability. That's definitely a theme coming through. And acknowledging that this is a large area, a large area, and it is distinct from, in its characteristics from the national picture. We've got lots of comments, so thanks very much. I don't know if anyone else wants to. Talk about?
I'd be interested from comments from local authority representatives in terms of this isn't just about a health focus. Local authorities, children's services, schools also have a part to play with this. So I'd be interested in any responses specifically from local authorities.
I'll move on the question just with time to the next one on Mentimeter as well.
Okay.
So people can answer that now.
Any practical examples that anybody wants to feed in at this point? We've had a series of practical case studies which gives you a flavour of what people are doing, but there will be much more going on. And again, what you've been given is sort of, to an extent, sort of health and voluntary sector. Where does the local authorities, because the local authorities are doing a lot of work around cost of living crisis and access to support for people who are struggling. And that's all part of this agenda. How are you getting on with that one, Will? Have you got any comments to feedback so far?
Just waiting for some comments.
Okay.
It was someone talking about, I think this is a really interesting point about physical activity and how you might support other, people engaging with physical activity.
And some of that, I suspect, sort of levels of physical activity in children and young people and levels of obesity have gone up during COVID. How are we addressing that?
And the social gradient has increased as well. So thinking about how you can engage those from the core 20 in any kind of intervention you make around physical activity.
Any comments from, and I'm not sure whether we've got anybody from physical activity providers. Again, sort of physical activity providers are mostly outsourced by local authorities these days, but some local authorities still run their own leisure services. And do put your hand up in the chat or respond if you've got any specific questions.
People definitely keen to focus their efforts on care leavers and that.
And again, I suspect there's a significant amount of work going on around care leavers. I know there's work in Teesside, and that's something again that we might want to pick up on and pull together.
Indeed, I put that in the chat earlier as well when there was some interest with the care leavers, Chris, so hopefully we'll have a connection for people.
Okay. Sarah Mills, you've put your hand up.
Yeah, just around the care leavers, I'm the designated doctor for Cared for Health for Sunderland, which is the central patch of the ICB. And we have a really strong regional group that we've already set up across the ICB. We had our first meeting a few weeks ago, so we'd be happy to link in amongst, you know, the designated doctors and designated nurses and anyone who is interested in kind of doing a bit more focused work on how we can meet the needs of care leavers, because there's lots of great work going on in our group that could probably be shared and avoid duplication.
Great, brilliant to hear, and we'll certainly take up that offer, because again, sort of lots of bits of good work going on, not always highly visible, and not everybody knows about it. And the more we can sort of publicize and get people involved and get people talking about it, the better.
Could we just go back to question 3? Yeah, perfect. Yeah.
Luke, you wanted to come back.
I did. I'm having terrible trouble putting the hand up because it's going up and down and up and down. It's not working for me. Anyway,
good exercise.
It's, yeah, exactly. Yeah, the modern day exercise. That I think there's a really interesting point here, because I think we're absolutely right, and I guess it's almost building on what you were just saying, Chris. There is lots of really good work going on. However, across North East and North Cumbria, we are facing some significant and severe health inequalities. So for me, there's this kind of broad question about how we can utilise the Core20+5 in bringing those together. Is this can as part of this framework we bring some of that great practice together? How can we work across the region to make sure that while there's great work happening here and there, at the minute it's not necessarily having, and it, you know, I'm sure there's people in the room that might challenge me on this, but it's not having the desired impact, because if we look at the data, if we look at the health inequalities that we see, they are still significant in those areas that we've highlighted. So I guess there's a really interesting kind of landscape, isn't there? And it's good that there's great work happening. How can we communicate across the region to learn from good practice that may be happening in pockets? And I guess to a certain extent, that's part of what we're trying to kind of explore through the work we're doing around self-harm that Will presented earlier. But it's an open-ended question, really. But you know, why are those issues still so prevalent? And yet we've got this great work going on. We need to kind of, you know, think about that strategically, don't we?
Okay, thanks. Will, have you got any more comments to feedback?
In terms of, yeah, the difficulties applying, is people have talked about time and resources, worried that it might just become a tick box exercise. Maybe what the kind of how do you know that you're doing it or not, or how you're achieving it or not, and the challenges in joining it all up, not reinventing the wheel, the issue about it not being widely known. So I guess there'll be people who hear Core20+5 and immediately know what it is, but there's going to be lots of people who don't. How we communicate that, really. Yeah, that's some of the points.
Okay. Do you want to move to the next question?
Yeah. So people will have a confidence rating. So if you can feel how confident you would feel in applying the Core20+5, and then I'll move on to a more open question.
Okay.
I suppose what we're looking for people to consider here is what they're looking from us and what we can provide to make people feel like they might be more able to use the framework within their own practice. I wonder if anyone has any thoughts.
I think the difficulty for me is that it's easier to focus on the 5 and think what you might do about the 5 in terms of asthma, epilepsy, mental health. It's less easy to think about the core 20, because the core 20 it involves an enormous range of people, organizations, communities, and pulling something together practically around the core 20 is much more difficult than pulling something together practically around the +5. But that's a challenge for us, because actually at the end of the day, this whole issue around sort of preventive health, aging starts at birth, and what happens in childhood influences what happens in adult life, and a whole range of problems around the cycle of deprivation, if you like. If you live and are brought up in a disadvantaged environment, then your educational outcomes are likely to be worse, your health outcomes are likely to be worse, and the cycle then repeats itself. Liz, do you want to respond to that?
Yeah, it's just to say, because the adult Core 20+5 has been out for a while, the trusts have all had to identify a senior responsible officer for health inequalities. So every acute community mental health trust, every PCN has to have somebody who's an SRO responsible for this. So they're not just responsible for the adults, they're responsible for everybody in their population. So they have been tasked with being able to segment data by deprivation and the wider plus groups, especially waiting lists for elective care and looking at their UEC data, etc. as well. So I think, I would challenge everybody to go back to your own organisation and make sure that you can identify who in your organisation's the SRO for health inequalities and what other work's happening already for adults in those wider areas, Chris, that you were speaking about, sort of like outpatients and elective care and UEC, just to see how that can dock into that bigger picture as well. So we're not starting from scratch. And I know the work Esther talked about, working with personalised care teams for people who do not attend, similar work happening with people who experience long waits for elective care. They've commissioned a personalised care hub across the North East and North Cumbria to support people from more deprived and challenged communities. I mean, I think the thing is to go back to that group and say, and what's the support for children and young people with that work as well. So there's a bit of mapping what's happening with adults to make sure we can broaden and learn from that for children and young people as well. So I just, yeah.
I'm just going to come. And do you think we should have an SRO for children and young people? I mean, we have safeguarding leads. Is this something we add to what safeguarding leads do?
So there will be a children and young people's lead for every organisation, would imagine. And I know the health inequalities, I think we should be pushing for the health inequalities SRO within all those organisations to cover their whole population rather than splitting it up, to be honest, because I think that's where we see the difference. Because when we're thinking about budgets, for instance, the 200 million that's come out across the country to support health inequalities work that was added in, every ICS got a proportion of that. Now it was 13+ million for North East and North Cumbria. And again, if that health inequalities lead has got the children and young people's agenda and priorities and they're cited on it, you're more likely to receive an appropriate proportion of that budget to address children and young people's health inequalities. There's something about making sure that it's joined up, because they will be sitting on the exec boards of their organisations or the ICB as well.
My perception is that most of that money went to the adult Core 20+5, and the children's Core 20+5 was a late arrival on the scene and kind of missed out on some of that.
Absolutely, Chris. It was just a catastrophe, and we fed that up to the national team back in March to say, if you don't launch this to the end of the year, all of the multi-year planning is coming through in the summer. So we will have missed the boat now. And they are, the official launch isn't until the 16th of December for the Children and Young People's Core 20+5. that they're not going to announce any further funding, and that boat has sailed now, unless you've got a really tuned in ICB who's decided to invest in children and young people, but a lot of it's gone to filling black holes as well, because it wasn't ring fenced either. So the enormous challenges around that. And you're right, terrible timing, and this coming out so much later, which again flags the overall inequality between children and young people and adults. So we just need to keep driving that home all the time.
Great. More power to your elbow. Esther, you wanted to come back.
Yeah, in terms of the resource and the SROs, I was going to say I agree with Liz. In terms of the health inequalities leadership across the system, it's been a life course rather than adults. So take myself as the health inequalities lead for my organization. It's across the life course, not just adults. And that's the same for all my colleagues across. What we'd been provided with to start with was the adult framework, which came in through the NHS planning guidance. And we were waiting on the children and young people's framework. But even before the children and young people's framework was put across, we were still talking around children and young people's priorities. So like when I shared with the DNA project, we didn't just look at attendance for adults only. And everything that we do, we're looking at it across the life course from a healthcare health inequalities perspective. In terms of the ICS healthier and fairer framework that's coming up, the Core20 Plus work group in terms of the healthcare health inequalities is still life course and not just adults. So although there may not have been specific funding pots assigned to specific projects, so let's say asthma, because that had not come out. I think we would probably need to wait and see what the national team come up with later on in terms of maybe additional resources for different projects, because there are always different ways of and means of looking at things. And the national pot 13 point something billion that came through, yes, that may have been assigned to certain things, but if we look at all the resources across the whole system, then there are still opportunities to do a lot more than just fixing on just that money. But I think there are some of the resources that we've got already. If we look at all our different as partners, from VCS sector to local authority to primary care, all the different partners, there are still opportunities for us to work on the children and young people's agenda. So yes, the framework may not have been published at the same time as the adult framework, but it doesn't mean that we were not looking at children and young people in terms of the healthcare health inequalities.
Okay. I might then argue that a greater bit of the cake needs to go to children and young people. If you look at type 2 diabetes, we've already sort of highlighted physical activity and obesity. Physical activity, obesity in children, type 2 diabetes in adult life. And if we're really going to get serious around addressing it, we need to do more to tackle those issues in children and young people around the whole issue of food security, poverty, physical activity, longer term.
Yeah, and again, the ICS obesity group is also looking at a life course. So, and that will link very much with what we do from the healthcare side in terms of the diabetes. But there's an obesity group already for the ICS who are looking at all the different elements of healthier weight across the life course. Again, so I think it's, you know, from one of the comments that I passed was, where do we collaborate with other bits of the system where they are leading on that in order to assure ourselves that the priorities that we've highlighted are being addressed adequately. And I think sometimes there's something about us identifying what we need to lead on and where we need to collaborate with others in the system to make happen. And probably maybe that's a conversation that we need to have in order to assure ourselves.
Okay, thanks for that. Liz, do you want some final observations from you?
I think Esther said it all, actually. No, it's really eloquently put. And I think it might be that we chunk this up a bit and have, you know, maybe a series of webinars to bring together all colleagues across in the different areas, interconnected programs, to just map out what's happening and build up. We've got fantastic assets in the northeast and North Cumbria, so let's build on that. There's been fantastic work done to reach into those very vulnerable communities by our local authorities during COVID. So fantastic work around co-production to drive up COVID vaccination rates. So let's build on that. You know, those relationships are there. We can't make those relationships happen overnight, but where we've got trusted relationships with those very vulnerable communities, we need to be building on that and working with our partners, and also working more closely with education, because our children and young people spend longer in education than they do in healthcare settings. And we need to make sure that we're joining all of that up as well. So I think, you know, there's lots of connections to be made. And I think this is the start of a conversation, really positive. Great to hear the feedback from everyone. Great to have Lorraine on for Directors of Public Health as well, to feed it back and to get some clarity around what we're doing. But I feel very confident that this is really building on and adding value to what's going to come out in children and young people's Core 20+5, and it sits in the wider health inequalities work, because again, the Core 20+5 is the healthcare inequalities piece of it. So I think you've done a really good job to start that conversation, and all the comments today have really helped to make it shape into a much clearer message to go out to wider partners towards the end of the year. So thanks very much for inviting me to this event. It's been fantastic to hear everything that's happening. Thanks, Chris.
Okay, thanks very much, Liz. That's a great ending. We're sort of running out of time. There's some final slides here. We will share the slides and the links. This is the beginning of the conversation. This isn't the end of the conversation. And there are sort of other ways here for you to engage, join the network. There's quarterly newsletter. There's a Tuesday newsletter. There's a whole range of stuff. So do get engaged. We do need to continue this conversation. The more widely we can have the conversation with a whole range of partners, the more successful we will be in tackling some of the ongoing social determinants of health, which so bedevil the northeast and North Cumbria. So thank you all very much. Thank you for participating. Thank you in particular to our speakers, Luke, Jenna, and Will, for putting this all together. We've had a great morning. You will be hearing more. So bye to me from now, and bye to everybody else. Thanks very much indeed.
And thank you, Chris,
everyone.
thanks ever so much. Really appreciate you stepping into the breach there and for the comments. And I think it's great to hear that we're ahead of the game in North East and North Cumbria, and that we're going to use the work and the feedback today to get us to the next stage. So thanks ever so much, everyone. Thank you. Bye-bye.
Thank you.
Thanks,
Thank
Heather.
you.
Bye.
Bye.